Good afternoon and good evening to one and all present in this platform. At this outset, I would like to thank Trained Nurses Association of India, National President Dr. Roy K. George, Secretary General Mrs. Vachla Dinagaran Madam. And in collaborative with us, the CME partner, Sprint Communications, and also the collaborative partner, Upin Diabetic Care. So I would like to thank all the participants who dedicated their own time and to listen this diabetic care in this presentations. So welcome you all. Without wasting much time, I would like to share my own ideas with existing supportive structure and share my knowledge with you people. I'm very happy to share my knowledge at this juncture. Let me share my presentation. This is academy, means it is acquiring knowledge on diabetes mellitus and insulin. So before getting into this module, first of all, we all would like to understand, or we must understand, the diabetes types and management. So what is diabetes mellitus? This is not a new terminology. This term, it was just labeled in the Sushruta time. Sushruta in the century, it was described as Madhumega. It is in Indian culture, it was described the label of diabetes in the term of Madhumega. And in the Egyptian 1500 BC, it was described the term of diabetes, the illness terminology diabetes. So this is not a new word. Diabetes, it is not a new word. And it was labeled as diabetes in the 2nd century. In the age of 2nd century, it was labeled as diabetes mellitus. So what is diabetes mellitus? What is the meaning of diabetes mellitus? Diabetes means it is a go through or a large urine output. Otherwise, it is a poly. You can just use the term poly or else increased urinary output. Mellitus means it is sweet or honey. That is the meaning of the word of diabetes mellitus. So it is simply, we can call it as diabetes, and it is a group of metabolic disease in which a person has higher blood sugar, either because of body does not produce enough insulin, or because cells do not respond to insulin that is produced. So this is the definition of diabetes mellitus. So what are the clinical manifestations or classical symptoms will be present in diabetes mellitus? One is polyuria, frequent urination, polydipsia, increased thirst. Poly means it is increased or frequent. Polyphagia means increased hunger. So if we look at the epidemiology in the global level and Indian prevalence rate. So prevalence, as we all know that what is prevalence, it is the existing plus additional new cases. So that is prevalence. So if we are just looking at developed and developing countries, there are chances of getting increased number of diabetes mellitus. As per the record of International Diabetes Federation, it has estimated that 451 million adults lives in diabetes worldwide in 2017. But this number goes to 693 million by 2045. And if you look in the Indian scenario, 40.9 million is expected to rise 69.9 million by 2025. Until otherwise, if you do not take preventive steps, if you do not take a proper strategy management to control the glycemic level, so this number will get increased. And the next one is types of diabetes. So many textbooks and many authors, they are telling about the types of diabetes mellitus in different ways. Means type 1 diabetes mellitus, type 2 gestational diabetes mellitus. Type 1 diabetes mellitus, it is otherwise known as insulin dependent diabetes mellitus. So why we are calling this insulin dependent diabetes mellitus? Because type 1, it is always require insulin therapy. It occurs at the young stage, even children and young age, and it is always detectable before the adulthood stage. And type 2 diabetes mellitus, it is non-insulin dependent diabetes mellitus. It results from insulin resistance. Because of the insulin resistance, or the beta cells does not secrete, even if it is secretes exact amount of insulin, but it will not be carried properly to the cell level or tissues level. That is the reason for type 2 diabetes mellitus. And gestational diabetes mellitus, the diabetes mellitus first time occurs during pregnancy, that is called gestational diabetes mellitus. A recent trend, one of the additional types of diabetes mellitus also added, that is type 3 diabetes mellitus or else type 1.5 diabetes mellitus. What is 1.5 diabetes mellitus? This is new entity in the type of diabetes mellitus, because this 1.5 diabetes mellitus or type 3 diabetes mellitus, it mimics the all signs and symptoms from type 1 diabetes mellitus, and also it occurs in the adulthood. That is called, it is called type 1.5 diabetes mellitus or type 3 diabetes mellitus. Otherwise, we can tell this term is LADA, means it is this later autoimmune diabetes mellitus in adulthood. That is the term it is given to type 3 diabetes mellitus. Now we will look at the risk factors. As per American Diabetic Association, ADA indicate two types of risk factors. One is non-modifiable risk factors. Second one, modifiable risk factors. What is non-modifiable risk factors? Which we cannot change it, which we cannot influence it. Like age, nobody cannot change it. Nobody cannot modify it. As it grows and it will go ahead. That is it. But we cannot change the age, ethnicity. Race, we cannot change it. Gender also, we cannot change it. And family history, that should be family history, it will carry. So that these are the some of the risk factors which we may not, the human factors which may not influence it in these factors. And some of the modifiable risk factors, one is body mass index, BMI, and depends upon the glucose level. So it may be the seriousness of the hyperglycemia will occur, and glycated hemoglobin level, that means HbA1c. If it is greater than 6.5%, then it may leads to type 2 diabetes mellitus, and physical inactivity, lipid profile. So these are some of risk factors we can change as a human being. If we think these are the risk factors, definitely we will change it, and we can keep control the diabetes mellitus. And number of complications arises due to diabetes mellitus. If we cannot control it, or we may not be able to make glycemic control, definitely complications will arise. If the disease progressions or the hyperglycemic state is getting processed or progresses, the complications, according to that, complications may arise. Number one, acute complication. Number two, chronic complications. So what are the acute complications? Acute means suddenly some sort of complications will arise. Acute complications, that is diabetic ketoacidosis. Second, hyperglycemia, hyperosmolar state. Hyperglycemia, because continuously the presence of glucose in the blood, it is called hyperglycemia. Then diabetic coma. If it is ketone bodies present, it carries to the brain and it leads to diabetic coma, right? So these are acute complications. And chronic complications, what happens if persistent existence of the glucose in the blood, it carries the target organ, target vital organs. In human body, what are the vital organs? Kidney, heart, then eyes, these are the things, brain, these are the target organs. Right. So if these hyperglycemia will target these vital organs, so what are the things will emerge if it is targeted to the vital organs? One is diabetic cardiomyopathy, diabetic nephropathy, diabetic neuropathy, diabetic retinopathy, and encephalopathy. These are the complications, chronic later stages of the disease. When the disease is progressed, so these are the conditions will arise. So these are the chronic complications. We will look at pathophysiology of type 1 diabetes mellitus. So why it occurs type 1 diabetes mellitus? So where this insulin is synthesized or produced? Actually, it is synthesized from pancreas. So in the pancreas, there are 4 cells are there. What are they? A cells, beta cells, C cells, gamma cells, and delta cells. A cells, it is glucagon, and beta cells will produce insulin, And C cells, it is somatine, and other cells are produced. Alpha cells are beta cells, very important. Here the beta cells, the eyelids of Langerhans produced insulin. Because of autoimmune responses of the body or production of antibodies or T cells, it targeted to the beta cells. So when autoimmune responses are there in our body, it targeted beta cells destruction will be there. When it gets beta cells destructions, automatically the insulin production will be reduced or it may lose. Insulin production will be lost. So when the insulin deficiency is there, the glucose uptake will not be carried out into the cells. So usually the insulin receptors are there in our body. Where are they? The receptors are present. Usually the tissues in the adipose tissue, exactly the adipose tissues, then muscles, skeletal muscles, and the liver. So these are the areas the insulin receptors are there. So when insulin get reduced because of beta cell destruction, the adipose tissue will not get adequate nutrition because it locks the insulin. The glucose will not be taken into the cells. So automatically the cells wants food, nutrition. If the cells not getting adequate nutrition or food, so the fatty acids and protein will be utilized. So free fatty acids will be liberated into the bloodstream. That is called increased free fatty acids. Then muscles also get starvated because inadequate nutrition. Glucose, it is not utilized in the tissue. It is just flowing into the bloodstream. And in the liver, glycogenesis. It activates the glycogenesis process and it liberates the glucose production. And it also targets the kidney. When all this, it leads to hyperglycemia. Automatically, when the body gets exceed hyperglycemia or when the body gets more glucose, it has to excrete it through kidney. Right? So that time, what happened? It is the ketone bodies also present. The ketones also, ketonuria will be present. If it is hyperglycemia, then it will be flowed, it will be excreted through urine. So polyuria, excess urination. When excess urination is there, what happened? It gets the dehydration. So polyuria and dehydration, polyphagia, that's why the symptoms appear in any of the diabetes mellitus 1 or 2. And number 2, diabetes mellitus, it is not genetic factor. Actually, this diabetes 1 is related to genetic predispositions or autoimmune responses. Here, it is not like that. The diabetes 2, type 2 diabetes mellitus, it is not related to genetic predispositions. It is related to U factor. What is U factor? It is because of improper dietary management, excess carbohydrate intake or obesity or other factors are there, right? So this is related to U factor. When it is U factor is there, insulin secretion, it is there, but it will not be carried into the tissue level. For example, if you are looking at the adipose level, increased lipolysis, increased free fatty acids release. And if you are looking in the muscles, decreased glucose uptake. So in the cell level, in the tissue level, if it is not properly utilized glucose, what happened? Tissues will get starvated. The tissues is not getting proper energy. Right? So glucose is just freely, it is flowing into the bloodstream. It is not entering into the tissue. It is not entering into the cells because of insulin resistance. Here it is insulin resistance is there. Insulin resistance. And what happens if it is insulin resistance is present, it activates the liver to increase the glucose productions. So all these areas, what happened? Again, it will lead to hyperglycemia only. Because hyperglycemia, why it occurs? The insulin resistance. Insulin is not properly utilized at the tissue level. Simply, if I want to say it, insulin, it is not properly utilized into the tissue because it imparts the glucose into the cells, into the tissues. That is the main function of the insulin. Main function of the insulin is impart the glucose into the tissue. If insulin receptor is not activated properly, insulin receptor is not binding properly, the glucose uptake will not happen in the tissues level. That's what it is the reason for getting hyperglycemia. Now, gestational diabetes mellitus. Gestational diabetes, what happened? If the targeted beta cells hypertrophy and hyperplasia develops during pregnancy. Once if pregnancy is getting over, it has to come to normal level. 10%, 80% it will regain into the normal level. If it is not regained normal level, it is present throughout the pregnancy. It is called gestational diabetes mellitus. And next one, it is how do we assess it? How do we assess or how do we diagnose the diabetes mellitus? As per American Diabetic Association 2021 recommendation, even WHO classification is also there. We are just following American Diabetic Association 2021 recommendations given in this slide. What is the criteria to diagnose the diabetes? If it is random plasma glucose level more than 200 milligram per deciliter and OGTT means oral glucose tolerance test more than 200 milligram per deciliter and fasting blood glucose level more than 126 milligram per deciliter and HbA1c. This is 3 months control. HbA1c, it is a 3 months control. So if it is more than 6.5%, so that is the criteria to meet any of the diagnosis of diabetes mellitus. So this is the criteria for diagnosing, clinical diagnosis of diabetes mellitus. Next one, how do we manage the diabetes mellitus? Okay, so what is diabetes? Type of diabetes we all see. Next one, and the criteria also we have seen that how do we diagnose the diabetes mellitus. Now we will see about management of diabetes mellitus. So what is our target? What is our goal? What are the goals of treatment? Any of the treatment, any disease treatment, to reduce the signs and symptoms, to manage the condition, or to prevent or delay appearance of the late disease, early identification, we have to do it, prompt treatment of particular condition, right? To reduce the complication, reduce the mortality and morbidity, maintain good quality of life. So these are main goals of any of the treatment. Of course, in diabetes mellitus also, the same goals it is applicable. And if the patient is hospitalized, what will be the glucose management? How do we manage the glucose management or glycemic management? There are so many barriers. If the patient is hospitalized, there are so many barriers, particularly in type 2 diabetes mellitus, because any type 2 diabetes mellitus, the identification, the 50% of the diabetes mellitus is undiagnosed. 50% of the diabetes mellitus is undiagnosed. And if we diagnosed 50% and getting proper treatment, only the 50% of the people are getting. I am not saying it is the evidence, existing evidence are just telling about this 50%, right? And if the person is hospitalized, there are so many barriers. First of all, the patient itself, it is negligence, right? Not getting proper awareness. This is very important. Any of the patient, any of the person is once the person is diagnosed as diabetes mellitus, the person himself or herself is neglecting. I am not getting. No, this is wrong answer. This is wrong result. This is first time only I am getting, right? So many things are there to clarify the persons to what you can say, accept the person is getting diabetes mellitus. And next one, it is family support is very important. If the person is diagnosed, that is also breadwinner is affected in one of the family and whole family will be suffered because treatment regimen, follow-up and their family support to taking treatment, proper treatment, prompt treatment, lifestyle modification, dietary management, so many things we have to see. So this is one of the things, dietary management, because Indian setup, and we are just many people, we are skipping the meal, right? And properly we are not maintaining the meal and time durations also. Nothing by mouth. Some of the procedures, if the person is in a hospitalized, if they want to do surgery, planning for surgery, so 8 hours nil per oral, right? Nothing by mouth. So that time also it is the glucose management is suffered. And if the person is in enteral or parenteral nutrition, that time also it will be affected. Next, medication. Medication effect also counter drug interactions or the changing of the medication regimen, or with the varying dosages of medications and side effect of the adverse effect of the medications. That's also the barrier in glycemic control. And another thing is physician not available. The physician is not available, or it is not accessible to the peripheral areas. That's also one of the, what you can say, barrier. And sometimes what happen, knowledge of the person or experience of the person in managing the diabetic care or planning the treatment, like that. So that is also one of the factor. And another factor is physiological factor. The person physiological stress, that is also the another factor. If the person is becoming ill, that is another factor, right? So if the person's renal function is impaired, their metabolic function is impaired, or risk of getting hypertension, risk of hypoglycemia. So these are the barrier or some of the influencing factors which we may not be able to maintain the glucose or glycemic level of particular patients when the patient is in hospitalized. And another important condition we all must know, diabetic ketoacidosis. So diabetic ketoacidosis, always as per American Diabetic Association guideline, this diabetic ketoacidosis always we have to treat in ICU setup, because continuous glucose monitoring is required. And it is a medical emergency. It is not a simple condition. It is suddenly it is occur. It is acute conditions of diabetes mellitus. It is a medical emergency, so that the person is suffered with diabetic ketoacidosis. It must be treated in the ICU setup of the hospital. And for this diabetic ketoacidosis, the restoration of fluid deficit within 24 to 46 hours and electrolyte replacement is required, and continuous monitoring of glucose and insulin therapy. Of course, insulin therapy is the treatment of choice for diabetic ketoacidosis. And next slide, it talks about inpatient management of diabetes mellitus. Yes, when the patient is coming diagnosed with the diabetes mellitus, admitted in the hospital, and what are the areas as a nurse or as a healthcare workers we all must see. The number one is whether the person is having hyperglycemia, right? So if greater than 140 to 180 milligram per deciliter, despite of oral therapy, if the person is persistently having hyperglycemia. Number two, the personal factors means the person's diet, nothing by mouth, or continuous or bolus tube feeding, parenteral or enteral tube feeding, whether the person is suffered with chronic kidney disease, any comorbidities are present, and insulin regimen, how the person's insulin regimen, whether the patient is taking oral pill or insulin therapy. So all the areas, the assessment and the diagnosis and all history collections, thoroughly is collected history from the particular patients will help the appropriate management for diabetes mellitus. Next is very important factor, dietary management. Dietary management is a big area. It is not, we cannot say it is a simple dietary management, right? Dietary management, it is MNT, that is medical nutrition therapy. If the person is diagnosed with type 1 diabetes mellitus, we have to follow for 2 to 4 weeks later and regular review after that. A key aspect of medical nutrition therapy is advised on carbohydrate amount, type, distribution over the day, taking into account the age of the person and their insulin regimen. So when we are planning any of the dietary management of the person, so we must take into account of the person's age, insulin regimen, and what type of carbohydrate they are taking, an amount, and whether the carbohydrate is throughout the day is sparing or only one particular time large amount of carbohydrate the person is taking or not. So this is for type 1 diabetes. And type 2 diabetes mellitus, definitely type 2 diabetes mellitus will be controlled with appropriate diet, right? So always we need to advise for low glycemic index. So low glycemic index, which are the foods it contains low glycemic index? The food contains whole grain bread, pasta, legumes, temperate climate fruits, and milk, yogurt. In Indian setup, if you just see some of good nutritions, like if you just tell about a bitter gourd, even if the person is diagnosed with diabetes mellitus, they will take one tumbler of juice, right? Bitter gourd juice, they will take it. And Indian gooseberry, that is amla. Amla is the one of the essential fruit that will reduce the glycemic level, right? So amla and whole grain, all whole grains, because whole grain, why we are encouraging the whole grain food? Because it takes time to convert the energy, because it is slowly, it will release the glucose. It is suddenly, it is not outbursted the glucose level. That's what we all encouraging to take whole grain food, right? And sprouted, sometimes if it is a deficiency of vitamins, folate and vitamin E, that all it contains in the sprouted grains, any of the sprouted grains, and we can encourage to take that also. And milk and yogurt. And low GI foods should be incorporated at all meals. GI means it is a glycemic index. And maintenance appropriate body weight is the key strategy, because obesity is one of the important factor which influence for type 2 diabetes mellitus. So 7% of the body weight loss, it is recommended 7% of the body weight. And for diabetes 2, 6 to 12 months MNT. Because type 1, it is early identification, young children will be affected, but type 2 insulin is the treatment choice for diabetes 1. But type 2, 6 to 12 months MNT is required, low saturated food, low sodium food, high in fiber diet, and low GI food, glycemic index food, and high fiber diet will be encouraged. Then reduced blood lipid level, because the saturated, less saturated fat, and because it will encourage the improvement of insulin sensitivity and also reduce the lipid profile. And no alcohol. Strictly we have to tell no alcohol, no smoking. So because these are the some of the influencing factors, increase the stress level, stress reduction of stress management, regular physical activity. According to International Diabetic Federation, 150-minute per week moderate or intensity aerobic exercise, or else 75-minute intensity aerobic exercise. That's it. They are just encouraging. So that we have to be planned for throughout the week. Not one day we have to take this minute, 150-minute or 75-minute like that. So throughout the week we have to be planned. And this is one day menu plan. According to the hospital setup, they will give whenever the patient is visiting to the diabetology care or diabetic clinic. So they will give one menu plan, because it is nearly 100 kilometers distance. What are the foods available, or what are the available foods which will help to reduce the glycemic level in the body. So they will give one menu plan. So according to that, the individual has to plan the personalized individual dietary plan. We must follow it. And next one, it is lifestyle modification tips and prevention of complication. What are the lifestyle modification? Right? So it include dietary habit. Dietary habit, how we have to encourage the person to take a whole grain food. All white we have to avoid, like means sugar white, salt white, atta white, right? So these are the things, all white products we have to avoid it. And physical activity. So physical activity, as I said, 150 minutes, 150 minutes, moderate to intensity exercise per week, it will be recommended. And exercise like according to the person age. If you are telling 80 years, the person with diabetes mellitus, you cannot tell them to run. No, So you have to tell them to take walking, proper walking exercise, right? Or else brisk walking exercise. Some persons will be suitable for swimming. Swimming is also encouraged. So likewise, according to the person age, gender, and the capacity of the person, they can do it. Like, so we have to recommend the exercise pattern, and regular monitoring of blood glucose is recommended. Physical care such as food care, every 6 months or 1 year, the regular food care will be followed. So therefore, we can manage the diabetes with the individualized level, because we have to target the individualized person. Not if we tell to the family members or somebody else, no. So once the person is diagnosed, we have to compromise, persuade communications, it should be there. And we have to tell in all aspects, not the initial visit itself. When the patient primary focus is to understand about the diabetes mellitus, because many of the diabetic patients, they are not understanding the seriousness of the disease, or strictly follow up of their habit, dietary habit or physical activity or exercise, or else regular monitoring of blood glucose. They are not just following it. So that is the main issue. So whenever you are seeing the issues of the individualized, according to that, you have to be plan it. And next one, it is the same thing. And if the person is prolonged sitting, and you have to be interrupt every 30 minutes. So just go for a slight walk and just come back to your seat. And yoga is also advised. Cigarette and tobacco, no. Completely you have to tell that for cigarette and tobacco, or else other alcohol. So these are some of the preventive methods. And one more thing, psychosocial care. Like when the person is first diagnosed as diabetes, definitely the disease will not go away up to for his or her life, entire life. Because once it's diagnosed forever. That is the thing. So if it is ever, means we have to compromise our physical condition, we have to compromise it as well. The mental conditions, mental well-being also, we have to be take care of it. Because diabetes long, if it is progress, if it is 1 month TK, they will accept it. Second, third month, and they will get tired, fed up with the diabetes. Then I have to go to take treatment, regular treatment. If I am not taking a proper regime of the treatment or dosage of the treatment, and if I am not visiting to the hospital, this is condition will worse like that. And another thing is income, right? So that is the burden to the family also. Kharcha karna padega. They have to spare their amount. So that's also one of the burden. And they have to take leave or for the taking treatment, all those things. So it gets mental distress to the person. Automatically, the person will get depression, anxiety, disorders in eating, and cognitive capacities. The patient, so according to the cognitive ability of the patient, we have to compromise the patient. We have to explain appropriately to understand about the condition, live how happily with the condition. Right? So how to control the glucose level, how to control the glycemic level, how to go for regular checkup, how to do their plan for their diet, how they can carry out their exercise, like that. If we tell, so little bit, they will just come for regular checkup and they will cope up with the disease conditions. So their coping ability with the disease conditions will be increased. And monitoring the regular checkup, diabetic distress, whether the person is affected with this distress, because it will go ahead for its complications also. And if the patient is having hypoglycemia, suddenly if it is any drug effect, the peak hours, if it gets hypoglycememia, so what the patients take precautions, that is also we need to tell. Because if the person is getting glycemia, suddenly the hard candy or sugar or easily digestible carbohydrate, fast-acting carbohydrate, 10 to 15 grams, we have to be advised it. So like this, we have to tell the person how to take care of themselves when the patient is getting hyperglycemia and hypoglycemia. And another thing is, whenever the patient is going long travel, or else for any heavy exercise, or they are just air traveling. So we make sure, or we have to tell them to carry the diabetic medical alert card. So for their betterment or for their health benefit. And another thing is the novelty of medical treatment of diabetes mellitus. What is that? What is that? Remote real-time continuous glucose monitoring. It is a fantastic work done in Corona time, COVID-19 pandemic. It is a peak time. Really, this was helped a lot. Continuous glucose monitoring, CGM, right? So CGM, otherwise you can say it is AGP also. AGP, it is ambulatory glucose profile, right? So this is the diagram. This is the diagram. When sensor is there, this is the sensor, CGM device sensor is there. So when sensor, if you attached on the abdomen, or else this is a self-faced CGM is also there. So if we keep it, that sensor backside the upper arm, backside of the upper arm, if it is just fixed, that sensor on the upper arm, it will just take what you can say, that the sensor will detect every 5 minutes what are the changes of the glucose level in the body. It will detect it, and it will just present in the, whether it is the reader is there. Reader, we can just identify. If you keep that reader, it will sense near to the device sensor. If you keep that reader near to the sensor, it will take that reading. So you can just see in your mobile how much it is there. So it has some memory. Reader it is having a memory card. When you just put it into the laptop or any of the computer system, it will show in a graphical manner, right? In a graphical manner. So sensor to reader, transporter is there, right? So all the data, clouding data, it will be converted and it will show in a graphical manner. So we can just see 70 to 110 whether the line is there or not. If it is above, so what we can do it. So the doctor will tell what is the treatment regime, like that. So if type 1 diabetes, type 2 diabetes mellitus, if we want to regulate, we want to see this one, continuous glucose monitoring. In case of, for example, pregnancy, this is advisable. Nowadays, the person, what you can say, gestational diabetes mellitus, this CGM, continuous glucose monitoring, for 2 weeks they can keep the sensor on the upper arm, right? So this 2 weeks it will be monitored, and this 2 weeks, entire 2 weeks, the glucose level of the glucose, it will shows as in the graphical form. And according to that, the doctor or a physician will tell that what are the regimes you have to take it, or what are the precautions you have to take it, like that. So this is really, it works very nicely. This is CGM. Continuously, it will monitor the glucose level. That is the real time. Continuously, it will monitor the glucose level. This is the instrument. And next one, it is omnious octet. What is omnious octet? Really, this type 2 diabetes mellitus, it has some underlying pathology. This omnious octet means 8 important reason why the type 2 diabetes mellitus is occurred. So this is a pathophysiology disturbance. Why this type 2? One is the reason is you are telling this obesity, dietary management, physical inactivity, systemic conditions, hypertension, lipid profile increased, all those things, right? But inside, if the type 2 diabetes mellitus, if it occurs, so what are the inherent factors? Inside inherent factors, one is decreased insulin secretion because insulin resistance, right? Insulin secretion is decreased. Decreased incretin effect. Incretin is secreted in the gut. So it helps for digestion. Decreased incretin effect. Increased lipolysis. Free fatty acids, if it is increased ketone bodies, that it will leads to ketoacidosis, right? Increased lipolysis, increased glucose reabsorption, and decreased glucose uptake into the cells, because the cells is not taking proper glucose, is not utilizing proper glucose. Where it will go? In the bloodstream only. Again, it will be leads to hyperglycemia. And some sort of neurotransmitter dysfunction, like the person is getting hungry, too much taking food, carbs food, like that. Some sort of neurotransmitter dysfunction. and increased hepatic glucose production, because it activates this insulin. If it is not properly secreted or insulin secretion is decreased, it activates the liver. You just produce more glucose. I am not coming like that. My amount is decreased like that. So it will just giving signaling to the liver, you activate more glucose. That's what it is, increased hepatic glucose production and increased glucagon secretion, right? Alpha cells. So glucagon secretion is also increased. So these are 8 factors. It is collectively known as omnious octet. So these are main 8 factors which will contribute to getting pathophysiology in type 2 diabetes mellitus. This is the figure. It shows the 8 factors only. Again, I will tell you: decreased insulin secretion, decreased incretin effect, increased lipolysis, increased glucose reabsorption, decreased glucose uptake, neurotransmitter dysfunction, increased hepatic glucose production, and increased glucagon secretion. Next, we will see about oral glycemic medication or oral glycemic agent, OGA, right? Oral glycemic agents. What are they? Oral glycemic agents. One is, as we all aware of that, as a paramedical, healthcare workers, nurses, all we are aware of what are the medications are available for treating diabetes mellitus. It is not a new chapter or new thing, right? So one is Metformin. Metformin is the one of the first foremost choice for diabetes mellitus. That is bigonides. Bigonides, that is example class is bigonides, example metformin. What is the action of metformin? It increased peripheral insulin sensitivity and decreased hepatic glucose production, because whenever insulin decreased, right, it will activate the liver, secrete more production of glucose. Like that, it will give signal. So it reduces hepatic glucose production in the liver and increase peripheral insulin sensitivity, right? And next one, it combined with always sulfonyl urea derivatives. Bigonides always it gives with sulfonyl urea derivatives, tolbutamide, like that, right? So it gives with this class agents, hypoglycemic agents. And next one, GLP-1 agonist, DPP-4 inhibitors, and SGLT2 inhibitors, and thiazolinated drugs, and others also. For example, if metformin and this bioglitazone and metformin, same action. You just see increased peripheral insulin sensitivity. There also increased peripheral insulin sensitivity. What happened? This metformin, if it gives weight gain, it will not gain much weight. But here, this glycotrone, it increases the weight also. That's the reason if the person is having more weight, fluid retention, you just see side effect. So that's what fluid retention given. So that is the side effect of the drug. If the person is having obesity, that you cannot give this medications. You have to see the combinations, metformin, which drug we have to give it, like that. And one more thing, if the person is using or the person is taking long-term metformin, so there may be adverse reaction also, B12 deficiency. So the person is screened for B12 deficiency or anemia, like that, we have to be screened it. So these are the main adverse reaction of any oral hypoglycemic medication. So each and every medications, it has its own adverse reactions. So that we have to tell to the patients how to compromise with that drugs for the betterment of managing glycemic level. And this is glycemic control algorithm from American Association of Endocrinology, College of Endocrinology. So this is one is monotherapy, dual therapy, triple therapy. Monotherapy, if it is less than 7.5%, if it is glycated HbA1c, and if it is more than or equal to 7.5%, HbA1c, if it is there, and we have to encourage for dual therapy. And if it is not meeting, then it will shift to the triple therapy, right? So these are the drug algorithm, glycemic control algorithm given by American Association of Clinical Endocrinologists. And next one is the same thing is here, the glucose lowering therapy for type 2 diabetes also. Here also you just see monotherapy, dual therapy and triple therapy. Only single drug metformin and with lifestyle management, and again dual therapy metformin with other glucose agents and with lifestyle management. And if it is not working and you have to be switch over to triple therapy along with lifestyle management, use regular glucometer with the strips or lancet for pricking the fingertip. This is very common. Whenever it is mass screening is there, the community screening of diabetes mellitus, this type of regular glucometer is using. How to use this glucometer? One is, first step is put a test strip into your blood glucose meter. Strip, you have to be insert the strip into the glucose meter and prick the fingertip with the tiny needle. Once if blood is squeezed out, one drop of blood, it will touches the test strip, right? So automatically within a second, the reading will come out, right? And you have to use it one strip for one time only. And you can use it for 10 times also for diabetes, type 1 diabetes mellitus, or it may be checked for twice for type 2 diabetes mellitus. So this is a way to use regular glucometer. This is all common, assessing the glucose level or to diagnose the glucose level. So what is insulin? And I wanted to say insulin is discovered in 1920, 200 years before the insulin is the discovery. Now 100 years, more than 100 years going on, insulin. Even then, all the triple therapy, monotherapy or dual therapy, insulin, along with other analog, all it is existed. But even then, somewhere else, some gap is existing. That gap we need to fulfill it. Right? So more than 100 years now, it's we are celebrating this insulin discovered more than 100 years. And discovered by, we all know that Banting and Best. So the persons discovered this insulin. And it is synthesized and secreted by beta cells. As I said earlier, where it is secreted, where it is produced, it is the beta cells. Beta cells, the eyelids of the pancreas of the beta cells. So that is the area where it is secreted. So how many eyelids are there in the pancreas? More than 2 lakhs to 18 lakhs eyelids are there. Eyelids, it's a small pocket like, right? It is a 2 lakhs to 18 lakhs eyelids are there in the pancreas. Around 200 units of insulin can be stored in the pancreas, right? So daily for a healthy adult person, healthy adult human, 200 units of insulin is stored in the pancreas. And how much needed per day? 40 units. So if we need 40 units of insulin is required per day. And this one is 2 phases. So the insulin is secreted in a 2-phase manner. One first phase, second phase. What is first phase? First phase, within a half minute, when the glucose production is hiked, right? Little bit rise of glucose in the body. Definitely within a half a minute, the insulin, it will go and attack. No, you just go down, control it like that. So this gives signals within a half a minute. And second thing is about 15 minutes and later on, it will be sustainedly, it will just release the insulin to maintain the glucose. So that is the news about insulin. As I said, human pancreas is there, comma shaped. Pancreas, what is the shape of the pancreas? Comma shaped. So here you can just go ahead. You can see islets of Langerhans. As I said, 2 lakh to 18 lakh islets of Langerhans. In that, beta cells are secreting insulin, synthesizing and secreting beta cells. Beta cells are secreted, right? So, and it will be targeting which one? It is adipose tissue and the muscles, skeletal muscles and liver. This insulin receptors, where all it is present in our body, these 3 main areas, the receptors are present. So this is the diagram, adipose tissue, striated muscles and liver. In the adipose tissue, what is the function? It increase glucose uptake, right? Inside the tissue, it will just, for this diagram, I will tell you, right? You just see this diagram, insulin act as a key. Right. So it just open the signal. You go ahead inside, right? Glucose, you are just coming in the bloodstream. The tissue wants glucose. So you go inside. So it will impart the glucose inside the tissues or cells. It acts as a glucose channel, insulin receptors. So if it is any problem in the key, if it is any problem, it is there. So in the key, if it is, this is the receptors. If it is in the binding receptors, if it is any problem is there, actually this is in type 2 diabetes mellitus, the problems is existing in pre-receptors level and intra-receptor and post-receptor level. In 3 level, there may be some problem to carry the glucose into the tissues. So this is the insulin resistance. So that is the diagram it's showing, right? And the role of insulin in maintaining blood glucose, as I said, same thing. Insulin is normally secreted by beta cells. And again, I wanted to say this thing only, right? So action of insulin, it is reduce the blood glucose. It is important anabolic hormone. And in the liver muscle, insulin increases the glycogen synthesis. It decreases the breakdown of amino acid in the liver, decreases lipolysis, increase lipogenesis. Right. So these are the main action of insulin. Right. How it will control? How does it helps to control the blood glucose level? One is low blood glucose level, high blood glucose level. Right. So when the pancreas, it gets activated whenever the body gets high blood glucose level, pancreas it's activated. So from the beta cells, it has activated an insulin production, and this insulin will regulate the blood glucose. So this is, the picture is clear now. Next, we will understand about the principles of insulin usage in diabetes. Why we want to use it? What is the underlying principles lying down in the usage of insulin in diabetes? One is insulin resistance. What is resistance? Insulin resistance means it is the state of lack of sensitivity or responsibility of the tissues to the insulin. So the tissues will not react properly, or inappropriate or impair or lack of sensitivity of the tissues to the insulin. That is called insulin resistance. Insulin resistance means the tissues is not reacting to the insulin. You are not my receptors, the binding receptors, it is not working properly. Insulin resistance. What are the factors affecting insulin resistance? One is impaired glucose tolerance. If the person having impaired glucose tolerance or impaired fasting glucose. So this is, you just importantly, you have to note it down in this area. Impaired glucose tolerance or impaired fasting glucose or leads to pre-diabetes. Pre-diabetes always carries to type 2 diabetes mellitus. So that's what we have to give keen attention to this area. If the person is having abnormal uric acid metabolism, dyslipidemia, hemodynamic changes like elevated blood pressure, if it is more than 140 mm of Hg, then also there may be a chance of getting insulin resistance. And prothrombic factors, any inflammation, C-reactive protein, white blood cells, so marks of any inflammation, endothelial, if it is any endothelial function, and other factors like body mass index greater than 25 kg per meter squared. So more than 30-35 kg meter squared, body mass index also, it influences for the insulin sensitivity. And if the family history of diabetes mellitus, hypertension, cardiac problem, and then sedentary lifestyle, physical inactivity, then the person ethnicity, the migrant race people, ethnicity people will get more resistance, and age greater than 40 years. So these are some of the factors which will affect to get insulin resistance. And type of insulin, as all we know that type of insulin is regular, intermediate and long acting. Long acting is ultra lent and intermediate acting is NPH and lenti. Short acting is regular. So this is bolus insulin, otherwise called as fast acting insulin. Basal insulin, otherwise called as slower or long acting insulin. So this is the chart, right? Types of insulin: fast acting insulin, long acting insulin, short acting insulin, medium acting insulin, pre-mixed mixture of fast acting and medium acting, pre-mixed mixture of short acting and medium acting insulin. So there are many types of insulins are there, like human insulin, From pork, the insulin is derivated, and beef, from the beef is also the human is derivated. So from the human, humalog is there, right? Humalog. So human insulin is also there, beef insulin, or from the pork. So from the mixture of this species, we cannot mix it together. We cannot administer the insulin. That is the underlying thing. We have to keep it always. Right. So the duration, fast acting and insulin, within starting 15 minutes, it will work. And long acting, 1 hour, it will start to work. So we have to take 30 minutes before the evening meal or bedtime. Short acting insulin, we have to take 30 minutes before a meal, because it will work as soon as starts 30 to 60 minutes, it will work. So other rest of the things, according to the variety or types of insulins, it will work. Next, what are the safety precautions we have to take it? Administering insulin. So don't think it, if you drink insulin directly, it will goes down. The glucose level, it will goes down. So don't think it up. So never drink insulin, the first one. Second one, do not share insulin needle, pen, cartridge with anyone else. So mine is diabetes, and other family members is also affected with diabetes mellitus. So I can share it. No, do not share insulin needles. Third one, talk to your healthcare providers and do not inject insulin in the exact same spot each time. So every time you cannot carry out, you cannot administer at a particular place or same place, because the chance of lipotrypsy also is there. And throw away needles in the hard containers like laundry detergent bottle, that can be closed. And check the expiration date. So expiry date, we have to be noted out, so that should not be used. And before taking insulin, you have to be rotate the site. The ideal site is abdomen, and thigh also we can take, right? So this is every time we have to rotate it. Every 5 to 7 days, you have to rotate the site, and the same site we cannot administer the insulin. And double check also, it's very important, name of the insulin, type of the insulin, what type of mode of insulin you are carrying, and what is the length, whether it is inbuilt needle syringe, insulin syringe we are using, or else other syringe we are using, that also we have to take care of it. So these are double checks, we have to do it. And right insulin dosage also, whatever prescription, whether it is the 40 units, 80 units or 100 units insulin syringe, or the amount or measurement of insulin in a unit, that also we have to be take care of it. And fresh needle for each use. So syringe and pens or needle, whatever it is used, so every time you have to use it, the fresh needle, right? Because short needles cause less pain. So that's what this fresh needle, we have to use it. And another one is the precaution measures for infections also. So that's also we have to use it, a new one. Another thing is warning signal of insulin reaction also. So what happened? High blood sugar. There may be a chance of getting high blood sugar also. Whenever getting insulin, there may be a chance of getting low sugar. So hypoglycemia. Hypoglycemia is very, very dangerous than the hyperglycemic state, because it mimics some dangerous condition. There is a rule. If the person is getting hypoglycemia, there is a rule of 15. We have to follow it. Every 15 gram of easily carbohydrate or candy or sugar, we have to be advised it, and watch for 15 minutes. Again, if it is monitor the glucose level, if it is not comes down, then again 15 gram, like that. So up to 70 grams we can just give to achieve the normal glucose level. And signs and symptoms also, the shakiness, cold, clammy, then confusions, nausea, dizziness, fatigue, anxiety, like that. So many symptoms will appear. So that we have to inform to the person, those who are affected with diabetes mellitus or those who are having diabetes mellitus, we have to clearly picture it, what is the warning sign or what is the reaction of taking insulin also, so that we have to ensure the patient, whether the patient is understood or not. That is a thing. And next one, it is avoid injecting at certain sites. So on the mole, if the mole is present and above the mole, you cannot just administer. If the person is having scar and near to the scar or above the scar, we cannot administer. If it is belly button, so that should not administer. So these are some of the area, because if you are administer on the mole and scar, it gives improper absorption of insulin. And also the storage of the insulin, do not heat or freeze the insulin. So you should not keep in the high temperature, or you cannot keep the insulin inside the freezer, right? So you have to be maintain it 2 to 8 degrees Celsius, and the room temperature you can open for 21 days also. There is no problem. And so no to expired products. So always you just check it before taking it for long days if you want to take it. So always you have to ensure it for the expiry date. And sometimes if my glucose level is high, so can I take it 10 more unit of insulin, or 20 more units, or 5 units more, like that? So you cannot, the person cannot take themselves according to their glucose level. That should not be taken. So you have to be consult with the doctors how much you have to take it, and the switch overing of insulin dosage also. And don't stick with the same insulin delivery device. So there are many things are available, insulin pens, pumps, and syringe, like that. So don't stick it on the same insulin delivery device. And insulin administration handling. So let me tell you the technique. What are the technique we have to use it? Because this slides is also telling the same points. Because each insulin cartridge, pen, or vial for single patient only, and labeled with the patient identification. Before administering, as a nurses or as a healthcare workers, we all make sure that whether right patient we are administering. So this diagram, it will tell you justice. So right patient, right medication, and right dose, right route, and right date and time. So right route always subcutaneous, it is most of that time. And if it is the regular insulin, it will be the bolus IV also we can administer, and IM it is the off life. So it is which route we have to administer, that we have to be ensured. So what are the techniques we have to follow while administering insulin injection? So first we have to clean your hand, right? Apply hand hygiene, right? Make sure that your hand is free from contamination, right? Hand hygiene. Wash your hands simply, and prepare space to conduct a procedure, and apply appropriate personal protective equipment, whether it is gloves is required, or if you are carrying with the infective patients, so which type of personal protective equipment is required, that we have to be ensured. And the person is having allergy, right? If the person is, make sure that the person, whether they are having allergy to the insulin or not, right? So insulin, if it is any insulin allergy, how you can identify it? The redness, swelling, right? Or some itching will be there. So immediately we have to stop the administration of insulin, wait for 12 to 24 hours. Then whether medications is prescribed for allergy, that also we have to encourage to take the patients, right? And check for allergy, and blood sugar results is within target parameter. And check dose, type of insulin, and what method of administration, that all we have to see before administering insulin injection to the patient. Insulin pen. So insulin pen, you just see needle is there, pen cap, first of all pen cap, and the second one is needle and dosing dial. So what happened? Insulin pen are about the size of regular writing pen only. This is like a pen only. It is mimic like pen only. You open the pen cap, right? Here the cartridge is there, free-filled insulin cartridge, and just rotate the free-filled dosage like 10 unit, 20 unit, 30 unit, like that. You have to be rotated, right? The cartridge, pre-filled insulin cartridge, dialing or rotation of the dial dosage, and just prick it, right? So if you just prick, so the needle will inserted into the cutaneous, and it delivers the insulin. So this is the work of insulin pens is doing. And insulin pumps also, right? Insulin pump. So this is for continuous monitoring of insulin. This insulin pump will be useful. This is for unconscious patient, or else if the person is continuous, they will be put on insulin therapy, for example, type 1 diabetes mellitus. And if the person is needing more insulin continuously, so this insulin pump will be helpful for substituting long-acting insulin. And how you will drop insulin? So from the vial, how you will just take up the insulin into the syringe, right? First of all, wash your hands, gets up. You have to ensure it, right patient, right dosage, right type, everything, preparation, as I told, or as I said, this preparation steps. So you have to be ensure it whether it's appropriate patient, appropriate medications, dosage, and what mode of delivery of insulin, like that. So all the things you have to be prepared. And next one, roll bottle if needed. It's required some sort of application of heat with the hand, right? You just roll a bottle if needed, right? And just wipe on the top of the bottle with the alcohol swab. Sprit swab, you just wipe it and pull plunger down to the desired unit. How much unit you have to take it carefully, you have to be calculate 20, 40 or whatever it is, and push needle into the bottle and plunger down, right? Push plunger down. Then it is desired unit, you have to be check it once again, remove air bubbles, check it to see whether the correct dose you have drawn into the syringe. So this is drawing up of insulin. So administration of insulin. Again, I'm just telling you have to be perform hand hygiene, aseptic precautions, and the procedures where you are going to administer the site, where the location of the site, right? Whether usually the abdomen is the appropriate site, and also thigh also you can select it, but the around the belly, right? So you should not choose it directly to the belly area. So it is a little bit 3 or 4 to 5 centimeters away from the around the belly area. You have to be selected and see that any redness is there, bruising is there, lumpy areas is there, because continuous administration of insulin, what happened, there may be a chance of creating lipohypertrophy. So that is also we have to be noticed it, whether it is a mole is there, scar is there, like that we have to choose it. We have to see whether the proper place or location of the site, whether we are administering or not. And cleanse the skin with alcohol, swab it, dry it, and ensure the rotation sites. And so these are the recommended area. Choose the area, divide the area into 4 quadrants, and select the site within the quadrant to start injecting. So quadrant area you have to select it. So every day you have to, every time, not day, every time whenever you are administering it. So that 4 quadrant itself you have to be rotated 1, 2, 3, 4. So then again you rotate it. Then again you just change the site. Every 5 to 7 days you have to change the site also. Then this is the things I am telling. So 90-degree angle with inbuilt syringe, insulin syringe, and there is no issue. If it is not there, you have to be very careful to administer the injection. And mixing insulin. So mixing insulin, mixture of insulin, it is rapid or short or intermediate or long-acting insulin will produce a more normal glycemia in some patients than use of single insulin. If you are using single insulin, it is not giving always the management of the glycemic in an appropriate manner. That's what the physicians always recommend, the mixing of insulin with rapid or short or intermediate or long-acting insulins. When rapid-acting insulin and ultra-lengthy, rapid-acting insulin and ultra-lengthy insulin are mixed, there is no blunting of onset of action of rapid-acting insulin. A slight decrease in the absorption rate, but not the total bioavailability is seen when rapid acting with glutamine stabilizer insulin, that is NPH, are mixed. So always we mix it up with NPH. In clinical trial, however, the postprandial blood glucose response was similar when rapid acting insulin was mixed with either NPH or ultra-lengthy. So the clinical trials are showing this evidence only. Then the postprandial, after 2 hours of meal, postprandial blood glucose is responsible. Similar rapid acting insulin was mixed with either NPH or ultra-lengthy. So the mixing of insulin also we have to be ensure it. So these all according to the prescription of the physician, that we cannot decide it as a nurse, we cannot decide alone. So we must ensure it what type of insulin, dosage of insulin, and the site of the insulin, and the reaction of the insulin, the precautionary measures, what to be taken by the individualized patients, that also we need to ensure it. So that's the way we can just manage the diabetes mellitus, because the type 1 diabetes mellitus, it's the hereditary causes. But type 2 diabetes mellitus in the worldwide, 80 to 90% of the population is suffered with type 2 diabetes mellitus. So as if we just see in Indian setup, young age group, we are the younger age dividends in our country. So we all very careful. We have to save the lives of the young individual. If we target young individual, youngsters or adolescent and adulthood, definitely the number of hiking the hyperglycemia can be reduced. So this is by regular checkup and regular monitoring of glucose, dietary pattern, and the exercise. Then we can reduce the obesity, because in Indian setup it is, we can see the central obesity in abdomen more we can see than the other areas. So central obesity is here. So that is also a main reason, right? Central obesity. So obesity reduction, then other management, nutritional management, then the person, how they can recognize themselves for hyperglycemia and adverse reaction of the drugs, how to manage themselves, self-care management, then cost effectiveness measures. So, we have to customize the cost effectiveness measures. So that way we can manage the diabetes mellitus, and we can improve the quality of life of the individual and family. And at last, we can just improve the well-being of the individual, family, and whole community. At large, we can decrease the burden of the community or society. So with this, I want to conclude this topic. Thank you. Thank you for listening. Any questions, it's welcome.